Good afternoon, everybody. Welcome to Grand Rounds. Today, it is my pleasure to introduce Dr. Andrea Weber. Dr. Weber is certified by the American Board of Internal Medicine and also by the American Board of Psychiatry and Neurology. She attended medical school at the University of Iowa, where she stayed to do her residency and also received a Master's of Medical Education degree. She currently is Clinical Assistant Professor, Assistant Director of Addiction Medicine, and Associate Program Director of the Internal Medicine and Psychiatry Residency Program. The CME Committee is very appreciative of the fact that she was able to accept our invitation today to speak on caring for people with substance use disorders, and please join me in welcoming Dr. Andrea Weber.
All right, well, thank you, everyone. Once again, my name is Andrea Weber. I'm very excited to be here to talk about one of my favorite topics, which is just talking about how to care for people who have substance use disorders, and maybe more at large, just people who are using drugs. For formal sake, I do not have any disclosures other than the fact that I deeply care about this population, and at the end of the day, I love a lot of people who use drugs, and so hopefully at the end of this talk, you feel a passion similar to mine, and or maybe just have some more tools maybe to help this population in your own practice. So just to review objectives, we're going to be just reviewing how to diagnose a substance use disorder based on the DSM-5 criteria. We are going to be reviewing FDA-approved medications for alcohol and opioid use disorders. I decided to focus on this just because I think that in both inpatient and outpatient settings, for a lot of us, this is maybe not something that we learned in our formal medical education. This is something that can impact both inpatient and outpatient. And so hopefully focusing on this will leave people with some increased knowledge base, maybe some motivations to start utilizing some of these medications. And then lastly, we're just going to talk more broadly about how to incorporate some harm reduction strategies to care for people in our practices who are using drugs. So first and foremost, I wanted to go over the concept of maybe terms. Language matters, and we know that using the correct language provides a more welcoming environment. It reduces our burnout and our stigmatization as providers. And so just kind of overview of some terms. And so usually when we're referring to substances, we try to use the term substance or drug and not refer to it as a narcotic. Primarily reasons narcotic more and more has become more of a legal term. And I think in a medical sense, especially for people who have used drugs, because they have had a lot of interaction with the legal system, we try to separate those terms whenever possible and really try to keep it medically focused instead of using the term narcotic. Instead of using the term abuse, focusing on the language of something of a substance use disorder, or even just describing their use as maybe chaotic, maybe unhealthy. Abuse, again, it kind of has a stigmatized term. There's some morality associated with that term, and so we try not to use that anymore. Instead of using the term polysubstance, I do try and encourage people, especially our learners, just to really list out what substances or someone actually has a use disorder to, and primarily it's because it really communicates what can be most helpful for that person. If I know that someone has an opioid use disorder, a cannabis use disorder, and a nicotine use disorder, I know exactly what medications or what tools I might be able to provide them that will be most effective, rather than just referring to them as having a polysubstance use disorder. The next one is just kind of trying to use person-centered language, and I think there's been maybe a motion to do this more broadly, including people who have mental health concerns or maybe just chronic health conditions. So instead of using the terms alcoholic, addict, talking about someone who has a substance use disorder. Instead of using the term relapse, sometimes you'll hear us talk about someone has a return to use. And this was purposeful to try to convey just a little bit more of a benign term, because not all return to substance use means that someone has kind of fallen down all the way off the cliff. Sometimes it's just kind of a slip, in which case people can kind of maintain that hope, get back on their path of recovery and feel more hopeful for the future. And then at the end of the day, we try to remove terms like clean, dirty, staying clean. Again, there's a lot of stigmatization with those terms, a lot of morality associated with those terms. And so instead, especially when we're talking about testing, using terms like positive or negative testing, especially if you're talking about things like urine drug testing. And then instead of using the term staying clean, something like maintaining recovery, maintaining health, again, trying to stay away from that clean, dirty analogy. Okay, the next thing we're gonna do is I'm gonna give a brief whirlwind as far as what we understand about substance use disorders, what is happening in our brain, both anatomically, and then maybe how is that manifesting in our behavior. this is a working model. This is changing. And so what I present to you might be different in a week, in a month, in 6 months, but I wanted to make sure you guys had kind of the most up-to-date understanding that we have and what might be happening in someone who has a substance use disorder. And so we're going to start at this blue area, this binge intoxication phase. And from an anatomical perspective, we're focusing primarily on the basal ganglia. So if you remember your neuroanatomy, which most of us don't, and I had the luxury of being able to study beforehand for this, but we're really focusing on the nucleus accumbens. It's kind of our motivation reward center of our brain. And from a phase of substance use, this is part of the brain that when someone starts to experience a substance that promotes a lot of dopamine release, a lot of reward benefit, more triggering of this area is going to facilitate a lot of compulsion to continue using that substance, as well as really drive that desire to seek out that substance, in which case the substance is going to start to increase in its salience. It's going to become much more attractive, much more important to that person. Now, if we kind of progress through this cycle, after this basal ganglia has been repeatedly offended, we get down into this extended amygdala, and this kind of phase in the red is the withdrawal of negative affect phase. And so anatomically, again, what we're talking about with the amygdala is this is kind of our emotional stress center of our brain. And in addition to the amygdala in this case is also talking pretty heavily to the hippocampus. And our hippocampus is primarily associated with our memory formation. And so we have strong emotions, strong experiences with something, and we retain that memory of what caused that or how that felt. And so in the binge intoxication phase, someone might have a lot of stimulation of their basal ganglia related to a substance. If for some reason that substance is then removed, people are in this dopamine deficit phase. We know that the receptors get downregulated. There's maybe not enough dopamine in the system compared to how it was when they were repeatedly getting stimulated with a substance, in which case people start to have a lot of negative drives as far as their behavior. They experience stress much more strongly. Maybe more natural rewards such as sleep or sex or food don't really trigger enough dopamine because of that dopamine deficit, in which case we just don't feel reward the same way. And so we experience that as a really negative drive, a really negative experience in that withdrawal phase. Now, extending that into this preoccupation, this green area on this graph, the preoccupation anticipation phase anatomically involves our prefrontal cortex, and our prefrontal cortex is kind of our executive functioning brain, part of our brain. It allows us to prioritize things, to make decisions. It's kind of part of our brain that helps us decide, okay, what's a short-term game versus a long-term game, and how do I prioritize that in the setting. And so you can imagine if someone's had repeated stimulus of their basal ganglia, they've had a lot of dopamine around. Maybe if for some reason they don't have access, they're in this withdrawal phase, they're experiencing a lot of stress. Typical rewards just aren't doing it for them anymore. This starts to affect maybe how they're problem solving. And so they might start to get preoccupied with feeling good. And so they want to start to seek out something that allows them to do that, in which case our brains are really good at trying to seek out the thing that we last remember helping with our distress. And so for some people who are with substance use disorders, that is the substance. And so you can kind of see that over time, especially to avoid that negative affect, to avoid that withdrawal phase, the ability to use a substance starts to increase on someone's priority list. They start to make decisions, in which case the substance starts to take precedent, maybe over things that traditionally would be more important to them, such as relationships, employment, things like that. So again, this whole system, by and large, can happen with most substances, especially substances that activate our nucleus accumbens, activate a huge dopamine surge in our brain. And you hopefully understand how people can get stuck in this cycle, especially people who go on to develop a really chaotic compulsion relationship with a substance. Okay, moving on. So we're going to be talking about then how do we diagnose a substance use disorder? And just as a review, our latest criteria come from our DSM-5, which was published in 2013. And this was the version of the DSM that took the abuse and dependence criteria and basically just did away with it. That said, here's the checklist. If you have 2 or more of these in the past 12-month period, you can be diagnosed with a substance use disorder. And then if you have more symptoms, that's going to qualify you for a more severe substance use disorder. And so looking at this list, you can see that people might have larger amounts or longer duration of the drug that they intend. They might have a persistent desire to use or be unable to cut down. They might describe expending a lot of time and energy trying to get a substance, use a substance, recover from a substance, and then subsequently describe a strong desire or craving to use. Their use might interfere with a lot of important things in their lives. They can't fulfill major roles. They continue to use despite knowing that it's causing them harm. And then people can use to the point that they develop a physical tolerance and then subsequently develop or experience withdrawal. Of note, especially when we're talking about opioid use disorders, having simply tolerance and withdrawal is not enough to diagnose someone with a mild opioid use disorder. So if it's only tolerance and withdrawal, that person cannot have an opioid use disorder. They have to have another criteria on the list in order to actually fulfill that criteria. Now, most of us don't want to memorize the DSM. I don't want to memorize the DSM. And so maybe a more simplified way to think about this is, do people describe symptoms that we can put into this category of the 3 C's? And so one is control. Are they describing an inability to control their use? They're using more, they can't cut back. Do they describe almost a compulsion? They spend a lot of time, a lot of energy, a lot of thought process trying to get a substance, use a substance. And then the 3rd C is the consequences. And that's, I think, something that a lot of people, especially when they're starting to engage with the healthcare system, hopefully seeking help, they might describe a lot of consequences related to their substance use, inability to do roles. They can't be the person they want to be, the father, the mother, the student that they want to be, in which case other parts of their life are starting to have significant dysfunction. Now, we've kind of reviewed how to diagnose a substance use disorder, but I do want to just remind people that not everyone who uses a drug has a substance use disorder. It might seem obvious, but I think sometimes we are promoted in that ideal, especially depending on what substance someone is using. So this is data from the National Survey of Drug Use and Health. It's a household survey that SAMHSA does every year, where they basically send anonymous surveys and they ask people about their mental health, their substance use over the past month and over the past year. And what we know from data from this survey, and this has been fairly stable over the past few years, is that when they extrapolate it to the general population, we know about maybe 21% of people surveyed endorsed using some sort of illicit drug over the past year. Of those people who endorsed past year drug use, by and large, it's cannabis. That's by far the most common thing, followed secondly by prescription pain relievers, maybe using them in a way that's not appropriate or not on their prescription list. Now, if you compare them then to the bottom graph, so the bottom graph is talking about people who in the past year have had a substance use disorder. The graphs aren't necessarily comparable one-to-one simply because the second graph also includes alcohol use disorder. But if you remove that, you see that maybe approximately 7% of people overall surveyed who have used a drug will have a substance use disorder. If you look at the illicit drug use disorder, that's about 8.3 million people. And so what that equals out to, and I apologize because you might just have to trust me on my math a little bit, but on average, when we consider all the people who endorse having used a substance over the past year, only about 10 to 15% of those people actually go on to develop a substance use disorder. So again, not everyone who uses a substance will ultimately develop a substance use disorder, and that really doesn't matter what substance we're talking about. We could be talking about alcohol, we could be talking about nicotine, we could be talking about cocaine, in which case it's helpful to know how to treat the use disorders, but also helpful more largely just to be able to talk to people about any form of substance use. Okay, so we're going to move on into alcohol use disorders, and so we're primarily going to be focusing on the medications that have been approved by the FDA to treat alcohol use disorders as maintenance medications. There are other medications that are not FDA approved that do have evidence and can be helpful for people with alcohol use disorders, but we will not talk about them. I list them here for your reference in case you wanted to look about them in your own time, and or if you have patients that are already on these medications, you might know that there is some evidence for that. So we're going to be kind of working through mechanism of action of different medications that have been FDA approved. And the first one we're going to start with is disulfiram. Brand name historically has been Antabuse. So disulfiram as a medication irreversibly blocks the aldehyde dehydrogenase inhibitor. And so if you look at this picture, you'll see that basically as people consume alcohol, if they cannot fully metabolize it to acetate, we see acetaldehyde start to build up in the system, in which case that causes people to feel pretty crummy. They can have headaches and fatigue and nausea, and overall just feel ill. So the idea of disulfiram is I take this medicine, and if later on in the day I decide I want to drink alcohol, I'm going to feel sick. And so disulfiram really works by saying, okay, I take my medicine. When I have a desire to use alcohol, I need to remind myself, you know, I don't really want to feel sick, so subsequently, I'm not going to drink alcohol later on in the day. It's really a kind of a behavioral negative reinforcement strategy rather than maybe mechanistically altering how we conceive alcohol in our brains. Dosing wise, it's about 250 to 500 milligrams daily. From a contraindication standpoint, the one that they focus on is severe myocardial disease. And I would say basically any chronic condition in which large changes of volume might cause problems would be conditions I wouldn't necessarily recommend disulfiram use. So the other one you might think of is things like cirrhosis or pretty severe chronic kidney disease. The other thing to remember is that if someone for some reason cannot remember that they took the medication or they don't understand what disulfiram is going to do if they drink alcohol, because maybe they have some sort of cognitive disorder, they maybe have a primary psychotic disorder, maybe they have some sort of neurodevelopmental disorder, they are not a good candidate for disulfiram because it just behaviorally will not work for them. They won't understand why they're getting sick if and when they drink alcohol on this medication. Because disulfiram irreversibly inhibits the enzyme, people can continue to get sick if they consume alcohol, even for 1 to 2 weeks after they stop the medication. Common side effects, fatigue, drowsiness, they can cause kind of a garlicky, metallic-y taste in their mouth, almost similar to metronidazole or topiramate. There is some concern for hepatotoxicity, so we usually do at least clinically monitor for liver function. And just as a general reminder, if people are taking disulfiram, that there is alcohol in other places. So there's alcohol in our food. There's also certain medications that can cause a disulfiram-like reaction if they take it in addition to disulfiram. As far as the evidence base for disulfiram, I just think that disulfiram is effective, but it's effective for a pretty narrow population of people. And so this was just a graph. This was a study that was done in a VA population. It was a randomized trial, blinded, placebo-controlled. And basically what this shows is that for the group that was adherent to the medication, disulfiram worked for them. It might be a little misleading because it looks like, based on this graph, because the gray bar is equal to the blue bar, that disulfiram worked equally well or maybe even worse than placebo. But again, if people take a placebo pill and they think it's disulfiram and then subsequently they don't drink alcohol, that's kind of considered a positive effect. That's how disulfiram is supposed to be working. It's this study in particular that makes us know that disulfiram works better for people who are either highly motivated to stay away from alcohol completely or people who have the ability to have daily observed dosing. So someone who can give them their medication every morning, and they don't necessarily have to put too much thought or decision making into it. Moving on to our second FDA-approved medication is acamprosate. So acamprosate works for treatment of alcohol use disorder by helping to kind of modulate or dampen down that excessive glutamate response that some people with chronic alcohol use have developed over time. It does this by antagonizing the NMDA receptor. Again, can control cravings, can kind of somewhat alleviate some of that negative reinforcement that might cause people to return to alcohol use. Probably the most difficult thing about acamprosate is its dosing strategy. So the dosing is 666 milligrams 3 times a day. Because no pharmaceutical company would like to make a pill that's dosed 666 strength, people have to take 2 tablets 3 times a day. Most of us know in medicine that the more often someone has to take a medication during the day, the less likely our adherence is going to be consistent, which makes it difficult. The pro of acamprosate is that it has no interaction with hepatic metabolism. And so for people who have liver dysfunction, acamprosate is safe. The only thing we have to watch out for is if people have any decreased creatinine clearance, either the dose has to be reduced or it might not be a possible medication for them. Interestingly, from acamprosate, when we look at the evidence base as far as how effective it is, most of the positive studies for acamprosate actually come from European countries. A lot of our American studies have not actually shown acamprosate to be significantly effective. This Kaplan-Meier curve comes from a study that was done in Germany. There was 270 patients that they basically treated for acamprosate for 48 weeks and then followed them for an additional 48 weeks. And what they found was acamprosate did increase the amount of complete abstinence from the patients that were treated compared to placebo, and that effect did seem to carry over even after the treatment was discontinued. This second graph is just to illustrate that when we talk about side effects with acamprosate, we're really talking about digestive side effects as well as insomnia. So those are things that you would want to screen your patients for if they wanted to try acamprosate. Finally, we talk about naltrexone as a treatment for alcohol use disorders. And I would say, globally speaking, naltrexone is kind of our first-line medicine unless there's a reason why we can't utilize it for alcohol use disorders. So as a reminder, naltrexone is an antagonist at the mu opioid receptor. It can be dosed either orally or by a once-a-month injection. Contraindications wise, people who have active acute hepatitis, especially if it's symptomatic, people who have liver failure, again, we're talking about people with like end-stage cirrhosis, as well as people who are otherwise dependent on opioids. Those are not people that we can utilize or should probably pick naltrexone in. There is a black box warning for hepatocellular injury when it comes to this medication, and we will talk about this more over the next few slides. More common side effects with naltrexone is going to be nausea, headache, maybe some difficulties with sleep, and nervousness or anxiety. So looking at the evidence, naltrexone, especially the extended release version, does fairly well. So this was a 6-month randomized double-blind placebo-controlled trial. There was close to about 640 participants, and they did do an intention to treat analysis, which again, as far as quality of evidence, is always reassuring to us. And basically what they found is that their primary endpoint was how many heavy drinking days people did. So not necessarily if they were completely abstinent, but how much they drank, and if they basically kind of just like lowered how much or how often they drank. And they did find that naltrexone was statistically effective at reducing heavy drinking days, and that it did seem to be dose dependent, in which the 380 milligrams, which is the FDA approved dosing strategy, did outperform the 190 milligrams. When we compare directly naltrexone to acamprosate, this was a meta-analysis that took over 60 randomized controlled trials over a 40-year period. They kind of just made some global conclusions. Is that acamprosate seemed to be better at promoting complete abstinence from alcohol. Naltrexone might be better at reducing heavy drinking days, and that both medications seem to perform better if people had completed a detoxification period, as well as if people had more kind of recovery time under their belt before they started these medications. I would take this last point with a grain of salt, though. We know that anyone who's able to maintain a behavior for longer is much more likely to continue that behavior. And so I wouldn't necessarily use that as a reason not to start people on these medications as soon as they want to, as soon as they're interested in them. I think timing-wise, we should really take advantage of that moment when it happens, if people are ready for a change and interested in medications to make that happen. This was a study that actually directly compared acamprosate to disulfiram to naltrexone. It was completed in a Scandinavian country. And I thought it was just interesting because, again, it kind of compared all of our FDA-approved medications for alcohol use disorders. And what they found, actually, because, again, this study was done with participants who were voluntary, people who were doing observed dosing of medications, is that when doing the daily observed dosing, disulfiram actually outperformed everyone. So, again, it kind of talks to the fact that disulfiram works, but it's probably a narrow range of people who might be able to follow the behavioral portion of it to make it effective. But most of all the other medications were also successful. And I think potentially more importantly is just to reassure us that in this group, regardless of what medication people utilize, everyone's liver function testing actually got better. And so with improvement, with reduction of alcohol use, LFTs got better, even with addition of some of these medications that might be associated with liver toxicity. To again discuss further, so naltrexone, I think sometimes people know it exists, they know it can be helpful for alcohol use disorders, but a lot of our patients with alcohol use disorders also have some element of either fatty liver disease, maybe some alcoholic hepatitis, and we kind of get nervous of, well, does their AST/ALT have to be normal? How high can it be before I start this medication? And so basically, to give you some historical context, when we talk about the hepatotoxicity with naltrexone, it's primarily oral naltrexone, and it was initially found in a case series that was using naltrexone for people who were overweight. It was a kind of an obesity management study, and they were using oral naltrexone to doses of 300 to 400 milligrams daily, so a lot higher than we might utilize for alcohol use disorders. When they've actually studied how LFTs change with people who are taking naltrexone, what they find is that by and large, LFTs get better, AST and ALT get better. In the case study that I talked about when they were using naltrexone for weight management, even in the group that had elevations of AST and ALT, when they removed the naltrexone, everything seemed to resolve. And so if patients develop any sort of elevation of LFT or AST and ALT when they take naltrexone, it does actually go away with removal. But overall, naltrexone is felt to be safe in people if they have mild to moderate transaminitis when you're thinking about starting that medication, especially if we're pretty much convinced that that elevation is due to ongoing alcohol use. And some of our expert opinions and groups have weighed in on this. And so there have been a few different summits with SAMHSA, with NIDA, and with kind of the clinical services portion of SAMHSA, and they've come to very similar conclusions. They basically said that we know that naltrexone can cause liver injury, but it tends to be in excessive doses. Again, that 300 to 400 milligrams oral type of dosing. They say it is contraindicated with acute hepatitis and liver failure, and then they kind of lay it out like what they mean by that. And they're really talking about transaminitis that's like 10 times the upper limit of normal, especially if people are having symptoms of active liver failure. So we're talking about people who are pretty sick, not necessarily kind of the average person who's walking into our clinic to talk about their alcohol use disorder. Luckily, Vivitrol, which is the long-acting injection version of naltrexone, has not been associated with this hepatotoxicity, and so it does seem to be actually maybe a better option in that setting. They do recommend clinically monitoring people for changes of liver function, but not necessarily doing a specific amount of testing. They want people to start the medication right away, even if you don't have baseline LFTs. And even if someone is taking the long-acting naltrexone, even if they consume alcohol on top of it, they say you don't need to stop the extended release naltrexone, because if you remember from the studies, we know that naltrexone might actually work better to just reduce heavy drinking rather than stopping alcohol use altogether. So no need to stop that medication, even if people return to some amount of alcohol use after starting treatment. Okay, that was a whirlwind of talk about medications. We are going to transition into opioid use disorders. Again, we have 3 FDA-approved medications for opioid use disorders, and we're going to talk about them more specifically. The 3 medications we're going to talk about are methadone, buprenorphine, and naltrexone. We're going to start with naltrexone first, mainly because we just kind of overviewed it. So just as a reminder, mu opioid antagonist. It does have pretty strong affinity for the opioid receptor, which is a good thing when we're thinking about a maintenance medication that might deter people from using opioids on top of it. Usually when we're talking about naltrexone for opioid use disorders, we really do try to promote people to be on the once-a-month injection. We know it works better. It's much safer. We worry, a lot about people overdosing as far as if they have any return to opioid use. And so the long-acting injection is really the form of naltrexone I really try to emphasize if people choose to do naltrexone as part of their treatment. It's not a controlled substance. People don't get tolerant to naltrexone, which is a good thing for some people who just don't want to be on a medication that makes them physically dependent. The biggest barrier to naltrexone with opioid use disorders is that people have to be opioid free for about 7 to 10 days, depending on what opioid they're using, because starting it too early can precipitate withdrawal. So you can imagine if someone's coming into your office and they say, I want to get on medications for my heroin use, and you say, okay, great. If you want to use naltrexone, you have to stay away from heroin for 7 to 10 days. Most people are going to say, if I could stay away from heroin for 7 to 10 days, I wouldn't need to come see you. I wouldn't need medications, right? So oftentimes 7 to 10 days might as well be an eternity for a lot of people who are seeking help for an opioid use disorder. So as a way to transition to the other 2 FDA-approved medication treatments we have for opioid use disorder, I want to just review a graph. And this is a graph that I actually draw with my patients to maybe help them understand what's going on, how we're using the medications, what kind of the thought process is. And so we usually go over this idea that people kind of start in this normal physiological range when they get exposed to a substance. I usually say normal in quotes because normal is so relative. And oftentimes when people are being exposed to substances, sometimes they're not necessarily going through normal stuff. They're experiencing trauma. They're going through really difficult things. And so, but people get exposed to an opioid. They might have a positive experience with that opioid because of the intoxication effects. People have described it to me as feeling warm, feeling safe. They kind of felt like everything was going to be okay, kind of this hopefulness that maybe they don't feel at baseline. So whatever the positive effect, eventually that's going to go away as the drug gets metabolized, and they're going to return back to this normal physiological state. Now, for the people that might be at increased risk of developing a use disorder, so experiences of trauma, family history of substance use disorders, chronic untreated mental health, physical health issues, maybe being introduced at a younger age when their brain isn't fully developed, they might then say, well, that was a great feeling. We should keep doing that. In which case, they're going to start using more consistently, more frequently. That positive effect is going to go down until they get to this point where in their chronic state of use, which can happen even after a few weeks to a month, people are going to be in this phase where they're not really using to be in some sort of positive intoxication phase. Sometimes they're just using to stay as normal or functional as they can. So when they're not using their own withdrawal, they're using basically to stay as functional as possible. And this is usually where people are meeting me. This is usually where people are coming to seek treatment because they're sick of this. They're sick of this cycle. It's not working for them anymore. They're running out of money. They're losing things that are very important to them. And they just need an off-ramp. They need something that can help them stabilize. And so the goal with medications, as far as that are agonists of the opioid receptor, is to kind of keep people back in this normal range so that they can take all of that physical, mental, emotional energy and just redirect it towards things that are hopefully more important to them at this point, whether it's relationships or school or work or housing, whatever the case may be. So first and foremost, methadone. Methadone is kind of our oldie, but still a very good medication for opioid use disorder. It's a synthetic full agonist. It's very long acting. When we talk about dosing for opioid use disorders, most people are going to be taking anywhere from 80 to 120 milligrams daily. So a lot higher doses than maybe you see in kind of our chronic pain patients. Has a lot of downsides. So has a lot of polypharmacy, can prolong QTC along with a lot of other medications, can contribute to respiratory depression. So there is a risk of overdose, whether intentional or unintentional. If people start to develop other cardiopulmonary diseases, methadone can be a hard medicine for them to tolerate. Methadone is still very difficult to get. There's not a lot of opioid treatment programs in the area, especially in a rural state like Iowa, and there's still a lot of stigma associated with methadone. Just as a review, methadone as a treatment for opioid use disorder can only be dispensed or utilized from someplace that's considered an opioid treatment program. These opioid treatment programs or methadone clinics, as sometimes they're kind of more casually known, are credentialed by JCO and SAMHSA. They have a pretty strict protocol and guidelines they have to follow. They have to provide counseling. They have to have the ability to either provide or refer out for medical or psychiatric services. They oftentimes don't utilize insurance, in which case sometimes people are required to pay $10 to $15 a day in order to get their medication, which is a lot if you consider a lot of people who are there in early recovery from a severe substance use disorder. And something else to keep in mind is that most opioid treatment programs do not report to the prescription drug monitoring program. So if your patient is getting methadone from an opioid treatment program, you will not see it on their PDMP. Most of them just do not report because of confidentiality laws. An example of maybe how someone would get started on methadone, again, just because sometimes no one's ever seen this in practice. They've never done it themselves. And so this is just kind of a gross example of how this might start. So you might see someone who's just stopped using an opioid. Maybe 6 to 24 hours later, they start to develop opioid withdrawal. Typically, when the withdrawal starts, you might start someone on anywhere from 10 to 20 milligrams of methadone. You can then redose them every 2 to 3 hours with either 5 to 10 milligrams of methadone in that first 24 hours up to a maximum of 40 milligrams. And the goal really is to try to give them a dose that they tolerate without side effects, but also can try to get rid of that opioid withdrawal symptoms. Starting on day 2, you're going to start them at whatever dose you gave them in the first 24 hours. So if you gave them that 40 milligrams on day 2, you're going to start them, you're going to give them 40 milligrams again. And you might dose them daily up to the point that they're out of withdrawal. But then once the opioid withdrawal has gone away, the dosing increases become much less frequent. So you might only increase their dose every week until you might get up to that 80 to 120 milligram or whatever dose someone needs to really kind of shut down that opioid craving experience, which usually takes higher doses than necessarily doses that take to get rid of the opioid withdrawal symptoms. So last, as far as medications that we're talking about, is buprenorphine. This is one that's kind of the newer kid on the block. It was FDA approved in 2002 as a maintenance treatment for opioid use disorder. It is a partial agonist at the mu opioid receptor. It has really high affinity for that receptor, and so it sticks really well. It can kind of outcompete with a lot of other opioids for that receptor, which makes it kind of a novel medication, a very safe medication for a lot of people. It comes in lots of different formulations, all the way from a once-a-month injection to a sublingual pill to kind of implants, almost like some of our contraceptive methods. In addition to really high affinity, it's kind of slow to let go of that receptor. It can come either as a monotherapy or when it's combined with naloxone. And when we think of like typical treatment doses for buprenorphine, 16 milligrams is kind of the number to have in your head. That's kind of bell-shaped curve-wise. That's where most people, especially most people who are using heroin on a consistent basis, that's usually the dose that it takes to get them to a point where they're no longer craving opioids. One of the tricky parts, but I think maybe hopefully not so tricky, but this is something that I think people worry about when they're trying to learn how to utilize buprenorphine is when can we start it? And so I'm going to use this graph just to illustrate maybe the concept of when we start buprenorphine. And so one of the things we worry about with buprenorphine is we don't want to start buprenorphine too early in someone who has enough opioids still in their system. They have a lot of opioid activation still in their system, because what we know is if we start it too early, and say someone's opioid activation is up here, when we give them buprenorphine, because that buprenorphine, again, has really high affinity, it's going to kind of come into the system, it's going to kick that opioid out their system, it's going to attach itself. And the problem is that when it attaches itself, that full activation of that receptor is all of a sudden going to drop. So maybe that 50 to 60% activation mark. And that sudden drop of opioid activation is going to put someone into withdrawal, and we call that precipitated withdrawal. It's really unpleasant. Again, not medically dangerous, but if you put someone to precipitated withdrawal, the first thing they're going to want to do is get out of withdrawal, in which case people can actually then go use an opioid and potentially be at higher risk for a death by overdose in that setting. So we try not to start people on buprenorphine too early. And so then it begs the question, well, how do we avoid this? And there's basically two strategies. So one strategy is we want them to be away from an opioid long enough that they get to about a moderate amount of opioid withdrawal, such that maybe their opioid level is down here. Because then what happens is if their opioid activation level is low and we start to give them buprenorphine, we're actually going to increase the amount of opioid activation in their system. We're going to relieve some of that withdrawal, some of the withdrawal symptoms, and they're going to feel better. And this is kind of the best strategy we have from a traditional approach on how to start buprenorphine in a way that keeps people from going into precipitated withdrawal. It definitely makes them more likely to continue treatment in the future. This is, again, an example of how you might start buprenorphine in someone in kind of a traditional approach. So again, they might have last used an opioid. Depending on what opioid they're using, whether it's a short-acting opioid like heroin or a longer-acting opioid like Oxycontin, you might wait anywhere from 12 to 72 hours. You're going to do a objective assessment of how severe their withdrawal symptoms are. Probably the most common thing that we utilize is the clinical opioid withdrawal scale. You're going to get a score. If their score is usually 10 or above, that's usually a marker that they're ready to start buprenorphine because they're in enough withdrawal that you're probably not going to precipitate withdrawal. You're going to give them anywhere from 2 to 4 milligrams of buprenorphine in that first dose. If their COW score is closer to 10, you might give them 2 milligrams. If their COW score is maybe closer to 20, so their symptoms are pretty severe, you could go ahead and safely give them 4 milligrams, potentially get them feeling better quicker. Approximately 1 hour after that first dose, you're going to reassess them. Where are their withdrawal symptoms? Hopefully they've gone down. They might not be 0, but hopefully the score has gone down, which means that you have not precipitated withdrawal. If they still have withdrawal symptoms, you might give them additional dose anywhere from 0 to 4 milligrams, again, just depending on if they're still having withdrawal symptoms or not. And the goal in the first 24 hours is to give, I guess, up to 8 milligrams. The really goal is to try to get them out of withdrawal in that first 24 hours. And then the same way you did with your methadone, you're going to take that total dose that you gave them in the first 24 hours, and that's what you're going to have them take on day 2. And day 2 onward, you can start to adjust the dose of the buprenorphine depending on what they need as far as side effect tolerability, but then also to kind of shut down that opioid craving experience. Another way to start buprenorphine is to use what's called either a microinduction. Sometimes we kind of call it a low dose induction. But it's kind of a really gentle cross taper is the best way to think about it. So what we do is over a week, we'll basically have people start really low doses of buprenorphine while they're continuing to use what other opioid they're using. So if they are using heroin, we'll just say continue using whatever opioid product you have for that first week. And every day we're going to ask you to take smaller increases of buprenorphine with the idea that the buprenorphine is going to kind of come in almost covertly. It's going to come in, take over the receptors, but in a slow enough way, in which case we're not going to precipitate severe withdrawal. And the idea is that by day 8, people have been increased up to 12 milligrams total of buprenorphine. They can stop their other opioid, and potentially, best case scenario, we've kind of avoided them having to experience withdrawal altogether. So we don't even require that they have to get into that mild to moderate amount of withdrawal. And so for a lot of people, for various reasons, they might choose to do this type of kind of small cross titration. This table is literally a smart phrase in my note. This is what I give to people when we're kind of deciding how we're going to do this. And just for reference, there's a few different formulations of buprenorphine that we utilize. Subsolve is a brand name version that you might see people on, but we don't use as frequently just because it's still on patent. Suboxone is the more common as far as tablet formulation. And then it also comes in a sublingual film. Medicaid pays for the Suboxone tablet without any form of prior authorization, so that's usually the version that we start out with. So moving on to then, just kind of reviewing of what we know from an evidence base of how good these medications work. And comparing methadone to buprenorphine, buprenorphine, especially when it's adequately dosed, and this study was greater than 8 milligrams, basically buprenorphine is not inferior to methadone. So we know methadone works. We know it works very well. Buprenorphine is basically just as effective for people. And so they're kind of considered kind of equally good first choices for people, maybe just depending on location, access, what they're interested in taking. When we compare buprenorphine to that long-acting naltrexone injection, this study was published in The Lancet in 2018. I think it really illustrates this idea of one of the bigger barriers to start naltrexone is getting people actually started. And so when they did their intention to treat analysis, it showed that buprenorphine did better. And primarily it was because there was a huge dropout. There's a lot of people that just could not get started on naltrexone because they couldn't tolerate the detoxification period. Versus when they took the data and they say, well, let's just look at people that were successfully able to get on naltrexone. How did they do compared to buprenorphine? And by and large, both groups did great. There was no significant difference between the groups, both safe, both tolerable. This was another study that looked at buprenorphine versus naltrexone. And I show this because sometimes people are like, well, it makes sense to me that buprenorphine helps with my opioid cravings because it's activating my opioid receptor. But am I just going to sit there and crave opioids if I'm on naltrexone because it's an antagonist? And based on what we know, the answer is no, that people who are on naltrexone actually have just as much decrease as far as their craving for other opioids, if not a little bit better than buprenorphine, at least in this study. So again, non-inferior to buprenorphine for people that are at least able to get through that kind of initial detoxification period. Some of the other questions that come up is, so maybe you've decided you're going to start someone on a medication for an opioid use disorder, but then it's kind of this idea of like, well, how long is long enough? And there's been some studies that have helped us answer that. So this was a study that was done in Sweden. It was a year-long study where they took people who were active heroin users, and they basically said, okay, half of you are going to be put on buprenorphine, then we're going to taper you off, and half of you are going to be put on buprenorphine. We're going to maintain you for the entire year of the study. And what they found is, the group that was able to maintain buprenorphine, 75% of them were still in the study after a year. 75% of them were able to show objective markers of being without opioids during that study period, and all of them were still alive. In comparison, people who were put on buprenorphine and tapered off, none of them were still actively participating in the trial. And at the year mark, 20% of the taper group had actually died. Not all of these deaths were related directly to opioids, but they had a definite increase in mortality compared to the people that were continued on buprenorphine. So in conclusion, as far as what we know about these medications is that they do reduce death. They reduce mortality for people with opioid use disorders. And so when they've accumulated data, they've basically shown that people who are in treatment without medications for opioid use disorder are 6 times more likely to die than the general population. And we can cut that down pretty significantly when we add buprenorphine or methadone as part of that treatment. So again, buprenorphine and methadone save lives. There's actually not a lot of medications in the global aspect of medicine that have actually been shown to reduce mortality, and buprenorphine and methadone are 2 of those medications. So we really should try to use them to kind of their full benefit for the right population. And so then, when we're talking to people as far as how long is long enough, I think we're never going to have an answer to this, and I think it's going to change based on every person. But globally, as long as the medication, as long as the treatment is providing benefit, and that could look very differently for each person. So as long as it's decreasing their substance use and we're eliminating it, helping them with employment, education, their relationships, whatever is really their recovery goals, as long as those benefits outweigh the risks, we will continue treatment. My guess is as years come on, we're going to learn more about maybe long-term pros or cons about these medications, if there's any kind of long-term chronic side effects. But at this point, they seem to overall be safe, and people do tend to do well with more chronic maintenance therapy. Okay, so I'm going to round up with just reviewing harm reduction. So just as a concept, harm reduction is something that we apply a lot to different parts of our life as well as medicine. I mean, we recommend life jackets. We talk about condoms, helmets when we're riding our bike. I mean, we even recommended putting filters on cigarettes as a form of harm reduction. So it's just this idea that we are trying to help people make informed decisions about whatever their behavior is as a way to just help them reduce any potential harm. And this kind of flows very naturally into people who are using drugs. We know that there are some harms to it. There might be ways to help them reduce harm, even if it's not completely abstaining from that substance. So one of the first harms we might talk about is basically that various harms can come to people depending on how they're using their drug. So if people are taking a drug orally, that has kind of the lowest level of harm, versus as we escalate to people who are using their drugs by IV route or injecting them, that tends to come with the most severe medical harms that could come to someone. So as we kind of move through this protocol, we see that increasing amounts of harm, snorting, smoking. As we get to the injection level, we really do start to see the increased risk of bloodborne infections like hepatitis, HIV, increased levels of bacterial infections. They can have local soft tissue infections, difficulties with their vasculature that can then end up creating more long-term problems for people. And then regardless of use, always remembering that all of these methods are able of causing death, potentially by an unintentional poisoning. So what can we do, right? Well, one of the things we can do with this in mind is just when we're talking to patients, if they're really not ready to completely stop a substance, is maybe just talking to them, is there a safer way that they can do it? So if they have been injecting their cocaine, for example, pretty consistently, maybe talking to them of like, hey, have you ever thought about just snorting or just smoking your cocaine as a way to maybe decrease your risk of bloodborne infections, of local soft tissue infections? There's a different set of harms with that, but overall, the risk overall from a medical sequelae standpoint is lower at that route. So having that discussion, having that education with someone. The second harm I wanted just to review is the idea of a contaminated drug supply. So again, oftentimes people are using substances, they're not actually sure what's in them. So they might be purchasing or using something that's called heroin, but maybe what it actually is some fentanyl, maybe with some Benadryl or benzo mixed in. They really don't know. It's not like someone's putting a nutritional label on some of these substances. In the same vein, they could be purchasing what they think is Xanax, which may or may not actually be anything. Maybe it's some sort of benzo, maybe it's just Benadryl. Cocaine is a big one. Stimulants can be intermixed. Sometimes people think that they're using cocaine, but they're actually using MDMA. Maybe it's methamphetamine. And again, fentanyl analogs can be mixed and potentially contaminating a lot of these different supplies, which is probably contributing greatly to our increased risk of overdose deaths. And so again, what can we do? Well, there's an increased kind of drive to give people some tools that might be helpful to them. On a more individual level, people can purchase fentanyl test strips where they can actually kind of prepare and dissolve their drug, stick the fentanyl test strip into it to see if there's the presence of fentanyl. Knowing that there's fentanyl in their drug supply may not necessarily keep them from using it, but it could just help them say, okay, I usually take a 1 cc injection of heroin. This has fentanyl in it. Maybe I'm just going to do a 0.2 cc injection just to make sure I tolerate it, see how strong it is. So again, reducing that risk of potentially unintentionally overdosing. From a more broader perspective, there are places that they actually bring in mobile gas chromatography and mass spectrometry machines where they can actually tell you exactly what's in a drug. A lot of European countries, for example, will have these at raves or at concerts or music festivals in which people can bring drugs. They'll test it, tell you what's in it, then help people make a better informed decision about how or how much they might utilize that substance. And then the third harm that I want to talk about is just the harm of death. COVID has been exceptionally lethal when it comes to overdose deaths. We've seen an escalation of death by overdose. Over 93,000 people have died over the past year related to overdose deaths. And it doesn't really matter what you're talking about as far as all drugs, but then, really focusing on things like synthetic opioids, primarily fentanyl and fentanyl analogs, but even the stimulants are starting to become more contaminated and more associated with overdose deaths. So again, what can we do? How can we reduce that harm as healthcare providers? Well, I would encourage you guys to try to get naloxone as freely available to your patients as possible. So you can prescribe it. Medicaid does cover naloxone nasal spray. They usually cover about 2 doses a year, so it's not great, but it's better than nothing. People can still purchase a prescription under the IDPH standing order for that medication. The University of Iowa, in conjunction with the Iowa Department of Public Health, does have this telenaloxone program where people can call in and get naloxone mailed to them. And there are other various community organizations that also have naloxone available for free, one of which is the Iowa Harm Reduction Coalition. They have a hotline people can request to have some mailed to them. The other thing we can do is we can use our medications that we know reduce harm for opioid use disorders. We know that they reduce death by opioid overdose. And so I just encourage you guys, the latest update of the law basically said that they're no longer requiring the training hours in order to get your buprenorphine waiver, as long as you do not prescribe for more than 30 patients at a time. In this the slide, I basically just kind of put some of the tips or instructions. There's YouTube videos. There's a step-by-step protocol on SAMHSA's website on how to do that. If you have any interest in doing that, even if you only treat 1 or 2 people with your waiver, I would strongly encourage you to get it. We are always here to help. And by we, I'm referring to kind of our addiction medicine services here at the University of Iowa. And so we, as a group, are currently under the University of Iowa Addiction Recovery Collaborative, or the UI ARC. We have a multidisciplinary team of case managers and prescribers of various specialties. We have ER physicians, infectious disease doctors, psychiatrists, primary care doctors who all have experience prescribing medications for different substance use disorders. We are starting to create a program that kind of has more of an outreach and kind of almost like an echo model. And so happy to help out with people, especially if they have any questions about maybe how to start buprenorphine on their first patient. We love to help out with that type of stuff. More specifically, as far as our services, so we have clinics most days of the week, and then we have 2 locations where we actually have clinics where we see people. One's the main hospital, one is Eye River Landing by the interstate. We do telehealth, and so even if people can't get to us as consistently in person because of transportation or financial issues, we do telehealth services. We have case managers who will take direct self-referrals. And so if you have any patient who's interested, give them this phone number. They can text it or call it. It's a clinical work cell phone number, and our case managers will answer them and kind of help them triage that process. We also have a relationship with our emergency room that if people come in 24/7, they can get started on buprenorphine in our ER, and then they'll get a bridging prescription until their next appointment with us. So again, really focus on trying to reduce barriers for people who come in and they're kind of interested in getting started, especially on medications for opioid use disorder. And then just in case there's someone in this audience who's like, hey, maybe I want to take a little bit of some time away from my current practice. I'm interested in doing maybe some addiction medicine specialty care. We do have an addiction medicine fellowship at the University of Iowa. It's a 1-year program. Basically, most specialties can go into this fellowship. So we can train psychiatry, family medicine, internal medicine, anesthesia, OB, pretty much a lot of the primary care specialties. And so if you have any interest in that, please reach out to us and let us know. Okay. So last take-home points, things I really want you to take away from our time together today is just this idea that, again, not all people who use a substance have a substance use disorder. And so just trying to be able to get more comfortable talking globally about different types of substance use. We have medications, maintenance medications for people with alcohol use disorders that have primarily been shown to reduce heavy drinking, but then also help people can be completely abstinent. We also have great medications for opioid use disorders that have been shown to reduce morbidity and mortality. And that regardless of setting, situation, substance, there are ways to incorporate harm reduction into your practice that might help actually nudge someone towards recovery, help them stay safe in the meantime, and potentially save their life. So I'd encourage everyone to kind of take that with you. And with that, I'm going to stop talking for a minute, and I'm happy to take any questions or concerns that people have. All right, looks like someone asked, can nursing participate in substance abuse medicine training? So there are, so currently we do not have a dedicated fellowship or residency program for advanced practice nurses to do addiction medicine, but we're working on it. I'm hopeful in the next couple of years that will be an option for people, for our advanced nurse practitioners who are interested in doing a specialty training. Okay, well, just in case, I'm going to put my email into the chat box. If afterwards, in a day, in a month, whenever, if people have any questions, cases that come up, I'm always happy to help out, answer questions, whatever we can do to be more helpful. So please reach out.